taking care of my mind, body, and soul.
For me, self-care means community care.
I practice self-care by regular breast self-examination.
I practice self-care by creating or joining spaces that allow me to express myself.
Self-care is all about prioritizing me time.
I practice self-care by choosing to use a long-term birth control called AD.
Hello, I'm Christy Cade with the White Ribbon Alliance.
And I'm Cindy Garcon, Coalition Director of the Self-Care Trailblazer Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone: advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Trailblazer Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee, Advanced Family Planning, JPIGO, PATH, Population Services International, and most of all, White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Good morning, everyone. Good afternoon, everyone, depending on where you are located. Bonjour, bonsoir, selon le lieu où vous êtes. I am Dr. Jeremy Zungrana, your moderator for this session today. It is indeed with a great pleasure and honor that I will play that role, expecting that at the end of the day, everyone will be able to walk out being completely satisfied and inspired by lessons learned from the self-innovation to implementation. Let me take this opportunity to thank the organizer for this great idea. From me, I'm a health sociologist, program management, public health with more than 2 decades in leadership and experience managing complex latte health and child health across both public and private sector in sub-Saharan Africa. In addition, I'm now more oriented in policy and advocacy for financing and development and grant making. So today I am occupying the role of country director of country director of Bill and Melinda Gates Foundation in Nigeria since January 2021. Will consist, today agenda will consist of 3 panels with short break in between, and we'll have live simultaneous translation in Spanish, English, and French. This dynamic session will explore the landscape of HRS for self-use product, from what in the development pipeline and regulatory pipeline and policy barrier to enable introduction and scale up of self-care product in low and middle income countries. Case study from AIDS, self-testing and self-injection of subcutaneous DMPA, 2 areas where evidence has informed implementation and advocacy to strengthening the enabling environment for self-care in recent years. So for today, even as I mentioned in the show, we'll have three panel, and the first one will last 15 minutes, and we'll hear from 2 excellent speakers on self-care product and regulatory landscape. And the second and third panel will be dedicated to HIV/AIDS and family planning. I would like also to give some information regarding how to log into which language you need to select. So you will go under interpretation and select the language you want, and that will help you. So we will also make sure that when we are not talking, we mute our mic to allow others to not have interference on what we are going to do. But before that, I would like to invite you to introduce yourself in the chat box. Put your name, title, organization, country, and email. That will help
Thank you all for introducing yourselves. Jeremy will be returning shortly, and we can go ahead and continue to enter your name and your emails and organization entry in the chat. So just to reiterate, we will also have interpretation, as Jeremy said. You can select French, Spanish, or English for today's session. Thank you for your patience as we reconnect.
Natalia, this is Kim Whipke with White Ribbon Alliance. While we're waiting for Jeremy to reconnect, I'm happy to just keep us moving forward in the event. Okay, is Jeremy back?
I am back. I am back. Sorry for the internet issue here today.
No worries. Thank you.
Yes, I am back. And yeah, sorry for the internet connection. So for us keeping, as you can see, you can see how to select your preferred language. So this is something easy at the bottom. And we also remind people that the meeting is being recorded and you should keep yourself muted unless speaking. And we want you to use your chat bot if you have question and you like to build on someone question. So also raise your digital end when you would like to speak, especially during a presentation or during the Q&A, and also stay curious and engage. So if we can move to the next, and I would like to take the opportunity to introduce one Zoom question, and you can provide your answer in the chat. Yes. Provide your answer in the chat. Which of the following activities are considered self-care? You have one, exercise twice a week, doing a pregnancy test at home, researching contraceptive options on internet, D, both A and B, E, all of the above. So I hope you will be able to answer and help our speaker to see your level.
Perfect. We will have the poll open for 10 more seconds and then show what everyone answered. Thank you all for entering your answer in this poll. I'm going to show Jeremy the results now. Go.
Wow, very, very interesting one. So apparently you did a great job where 70% answer all of the above. So research contraceptive option on internet, doing a pregnancy test at all 9%, and exercise twice a week 2%. So I think for all of you. Now allow me to go straight introducing our next panelists, two famous speakers. And I would like to start with, and the title of the presentation is, as I mentioned previously, is on product and regulation. So we have Saumya Ramarao from Population Council, and she is a senior associate at Population Council and chair of the new and underused reproductive health technology caucus of the Reproductive Health Supply Coalition. She's an economist demographer with 3 decades of experience in policy, implementation, research. That
If we lost Jeremy again, this is Kim Whitby with White Ribbon Alliance. I'm happy to just quickly do the introductions for both Saumya and Lester, and then I can turn it over to Saumya, who will kick us off. So as Jeremy was saying before he was disconnected, Saumya is a senior associate at the I think he's still trying to speak. Tech change, maybe you could just mute Jeremy's line for now, and then we can talk a bit about how to get him back on audio. So Saumya is a senior associate at the Population Council, and she's the chair of the New and Underused Reproductive Health Technologies Caucus of the Reproductive Health Supplies Coalition. And she'll be giving us a presentation on the product landscape for sexual and reproductive health products for self-use. And then after that, we'll hear from Lester Chinery, who's Director of Programs at Concept Foundation, where he has responsibility for the research, innovation, country support, and market access in manufacturing and development program areas within the organization. Both have decades of experience and are experts in their field. So I'll turn it over to Saumya to start us off.
Thank you, Kim. And thank you, SCTG, for organizing this series and for inviting us to participate in this particular session. I'm happy to be here with all of you. Today, this presentation will focus on the range of self-care products that are currently available on the market, as well as those that are in the pipeline. We will touch upon how these products can help consumers and health systems alike. Next slide. Next. Now, as we know, and I think you have to hit a second time, for there's a second picture on this. Thank you. So the self-care movement has received impetus from the WHO with the issuance of guidelines on how self-care can be integrated into health systems. As we heard earlier today, self-care is defined as the ability of individuals and families to maintain and promote their own health and well-being with or without the support of a healthcare provider. And the emphasis is on three different aspects: self-management, self-testing, and self-awareness. Where self-care products fit into this gamut of options is that it helps individuals to figure out which products that they want to use and in the ways that they feel comfortable using these products. So overall, the emphasis is on empowering health consumers to manage and maintain their own health, while also figuring out what the connections are to the health system. Next slide, please. The concept of self-care fits very well with global policy contexts and policy commitments, whether it is the SDGs or the ICPD and Beijing plans of action. And particularly, it fits very well with the Astana call for people-centered care. As you all know, the Astana Declaration of 2018 builds on the primary healthcare movement that was started decades ago. Across all these policy commitments, there is a uniform focus on gender equality and creating the enabling conditions for health consumers to be empowered and engaged to manage their health and well-being. Especially helping girls and women manage their own health is a key focus and is under discussion right now in Paris with the convening of the Generation Equality Forum. Clearly, self-care technologies can contribute to the vision of health and well-being and empowering health consumers in across all these policy documents. Next slide, please. Self-care technologies offer benefits to both health consumers as well as to health systems. Now, the benefits to the consumers are several. They give users control over the product they wish to use, when they wish to use, and when to stop using the self-care technology. They can use the product within the privacy and comfort of their homes. And in some cases, these products can be used discreetly without others being aware. There are benefits to the health system as well. Self-care technologies allow the possibility of some care aspects to be task shared or task shifted to health consumers themselves, thus offering relief to health systems, especially when there's a shortage of human resources. Furthermore, self-care technologies can be provided through multiple outlets, from health facilities to pharmacies to community-based drugstores and community-based health workers or distributors. So all these potential points of care expand access to health consumers and therefore increase coverage. Thus, self-care technologies not only address consumer needs, values, and preferences, but can also reduce cost and allow for more efficient use of existing health system resources. The hope is that with all these innovations, will result in improvements in health, reductions in health disparities, and increase in equity. Next slide, please. So when we begin the process of R&D, the first step is design. And in this important step begins by listening to what consumers say their health needs are, the problems that they have with existing products, and the attributes they would like to see in a new product. For example, when asked why women who want to avoid a pregnancy are not using contraception, the two top reasons women say are that they have health concerns with the existing contraceptive options or that they're having infrequent sex. So the design of a new contraceptive would therefore take into account what users are saying. It's just as important when we design products that they can be used in the health systems where we want them to be available. For example, self-care technologies that might need a cold chain may not be practical in settings where the electric supply is interrupted or where it can be ruptured very easily. So one way to know if you have a good product is if it meets the AAAQ standard. That is, when the product is available, is it accessible, is it acceptable, and is it of good quality? So these are some principles to keep in mind during the design process. Next slide, please. Here we'll talk about some of the healthcare products that are self-care products that are currently available in the sexual and reproductive health space. Some of these are well known and include oral contraceptive pills, emergency contraception, male and female condoms, and self-injections. There are other contraceptives too, like vaginal contraceptive rings, diaphragms, and patches that are increasingly becoming available in some markets. At this point, I would like the audience to put in the chat box the sort of products that you recognize and are seeing in the context where you are. It'll be interesting to hear what you also have to say. In addition to contraception, there are other products that are available for other aspects of sexual and reproductive health. For example, we have medication abortion drugs that health consumers can use depending upon the provisions of the regulatory frameworks of the countries where these are available. Now, these drugs include misoprostol or combi packs that include both misoprostol and mifepristone. And depending on the regulatory provisions, in some countries, a woman can start using a combi pack by initiating mifepristone in a health facility and then follow up with the misoprostol at home. In the area of maternal health, countries have piloted the use of miso for the prevention of postpartum hemorrhage, especially for home deliveries. So women are given misoprostol during an antenatal visit, which they're asked to use at the time that they are delivering, especially if they're delivering at home without any trained birth attendants. In the area of HIV, there are antiretroviral drugs that health consumers can use for protection against HIV and as well as for managing it. So this would include, for example, PrEP as well. Finally, as this picture shows, there are diagnostics that users can self-use. These include pregnancy tests, HIV tests, and also self-sampling for HPV. Next slide, please. Now let us turn to some products that are currently in the pipeline. What this means is these are products that scientists are working on and hope to bring to market in the coming years. I'm going to talk about a few examples that my organization, the Population Council, is currently working on. The Population Council is testing a testosterone gel in phase 2 clinical trials. This is a contraceptive for men, and where the man applies the gel daily on his shoulders and upper arms. So we hope by creating a product for men that they can use within the privacy of their homes, we will enhance the number of contraceptive options for men. Work is also being done on multi-purpose rings that can provide protection against pregnancy and STIs, including HIV, or it can protect against various STIs. Finally, I want to show in this picture, the picture that is in the middle of the slide. This is a picture of a dual protection pill, which combines existing oral contraceptives with an existing PrEP to prevent pregnancy and HIV. This is a prototype or a model that we intend to use in acceptability studies. Now, there are other products that are under consideration by researchers across the world. And these include pericoital methods that women can use at the time of sex, especially if they think that they are exposed to infrequent sex. Other formats that allow self-use include fast dissolving inserts, films, gels, microneedle patches, and an interesting product that's increasingly being talked about is for men, is self-testing of semen as a test for fertility. So as you can see, there's a range of products that are currently being researched. Next slide, please. So just having a self-care product is not enough. You have to meet consumers where they are. And what I mean by this is that we have to help consumers know the range of products that are available, how they can access these products, how to use the product, and have help in using the product once they decide to use it. So you have to know your consumer and help them use these different products. Furthermore, excuse me. Furthermore, even after a health consumer has obtained a self-care product from a healthcare provider, and it could be, the provider could be a midwife or a pharmacist, and they've received initial counseling, the consumer can still be unsure about how to use it once they reach home. And this is especially true if the self-care technology is a format that health consumers are not used to. These could include vaginal rings or self-injections, and these are new product types that health consumers will need to get acquainted with to use them effectively. So we have to think of innovative ways of providing additional support, including digital support via cell phones or social media, or health visits by community health workers to support health consumers. So the mechanism of delivering the additional support will of course be context dependent. It will include on aspects such as feasibility as well as cultural relevance. Next slide, please. It's not enough just to prepare health consumers, it's also important to prepare health systems to receive a self-care product. And what do I mean by this? So some considerations that we need to pay attention to are the policy and regulatory framework, such that they're conducive to making these self-care products available and accessible, while at the same time ensuring safety of health consumers. My colleague Lester Chinery will be talking about this in the next segment. Providers too will, just like consumers, will need to be oriented towards self-care products, especially if they are required to provide effective support to consumers. This orientation will be especially necessary if the product format is new, or if it is for a different indication, or if a new cadre of healthcare providers, such as chemists or drugstore operators, are being deployed. It will be equally important, I think, to emphasize that self-care products can alter the existing dynamic between a provider and consumer. It changes the power differential between healthcare providers and healthcare consumers. The healthcare provider might have to step back and take on the role of a supporter rather than a giver of advice or the service. Providers will need to be helped to understand how to navigate this change and be reassured that they're not losing their prominent status. Finally, self-care technologies allow the possibility of a new type of healthcare provider, such as online pharmacists. Now, as online pharmacists become more common and available, both consumers and providers need to be comfortable with this sort of service contact. Next slide, please. Today's session, we talked about self-care products within the SRH sector. However, it will be important to locate this discussion that we're having today within the overall health transition that's happening around the world. The health transition is being marked by a reduction in communicable diseases and the emergence of non-communicable diseases. So non-communicable diseases include cardiovascular diseases, cancers, type 2 diabetes, and other chronic diseases. So some of these diseases, the NCDs, can be monitored and sometimes be even managed by patients themselves. So examples include self-monitoring of blood pressure for those suffering from hypertension, or self-monitoring for diabetes, as well as self-injection of insulin. So these are all the sorts of products that are currently available. And as we all know, there are other whole range of new products that are coming onto the market, such as wearables, as well as fitness trackers on our cell phones. We also know of CPAP machines that sufferers of sleep apnea can use at home. So we have to fit what we know of for SRH within this overall health transition that's happening. Now, self-management with self-care products will also require that we develop consumer skills and capacity and self-awareness and demand creation to support the appropriate adoption of new self-care technologies. And we also do have to support the health system. Next slide, please. So with these reflections, I want to thank you for your attention and time. And here are some resources related to self-care that might be of interest to you. Thank you. Over to you, Kim.
I think Jeremy is actually back with us to take over the reins.
Thank you so much, Saumya. I think let's go straight to Lester. Lester, if you're on, you're welcome. Thank you.
Thank you, Jeremy. So good morning, good afternoon, good evening to you all, wherever you are located today. So my challenge for today is to make a presentation about regulation, which is interesting, which I think you'll all agree is going to be a little bit of a challenge, but I'll certainly do my best. So today we're going to look at regulatory processes for establishing over-the-counter availability of selected reproductive health products. And we're going to focus specifically on contraceptive medicines. Next slide, please. So I think we are all aware that individuals, and in particular women and girls, have struggled to access services and medicines during this COVID pandemic. And this has included access to contraceptive options. The pandemic has certainly shone a light on this, but I think we all know that this issue certainly existed prior to the pandemic and is a little bit systemic. Increasingly, information, discussion, and access to products is moving online globally. New technologies are coming through, as Saumya reflected upon. Demand for self-use for contraception and medical abortion, however, has implications for regulatory processes, whereby we need to find the right solution, balancing quality, concern, safety, and efficacy against ease of access for users. So in a way, regulatory has an important forward role to play. And I think the question, sort of overarching question here, is to whether regulatory in respect of self-care can become an enabler rather than a barrier to access. It's a necessary process to ensure the quality of medicines and the safety of medicines. At the same time, in some circumstances, it can present as a barrier. So in particular, we're going to specifically look at the procedures which allow for increased self-use and how to transition appropriate products from prescription-only medicines to over-the-counter status and what that looks like. Next slide, please. So WHO have some specific recommendations for contraception as it pertains to self-care and interpret medicines available that should be available over the counter for sexual and reproductive health and rights that can allow individuals to make informed decisions regarding their contraceptive use and fertility intentions. And currently this includes self-administered injectable contraception should be made available as an additional approach to deliver injectable contraception, over-the-counter oral contraceptive pills, and over-the-counter emergency contraception. And much of the rest of the presentation focuses specifically on these because they are medicines. Next slide, please. So in response to some of the questions that I've posed thus far, earlier this year, we undertook and carried out some research to try to establish the existing situation in terms of how national regulators manage and process these changes, which can serve to facilitate self-care, and in particular, moving from prescription-only status to over-the-counter availability. So we undertook this small research project, analysing existing regulatory procedures for changing medicines from POM to OTC across 30 countries comprising the 6 WHO regions to facilitate self-use of contraceptives. We also did some secondary analysis of diagnostic tests limited to pregnancy, fertility and HPV self-tests, and also took a look at their regulatory and the formal statutory processes and pathways which allow for self-use of these diagnostics in 13 of the 30 countries. To try to determine whether countries had formal OTC medicines lists, and within those lists, what products were included and what was the criteria for inclusion. And I think quite importantly, we tried to identify whether there were any regional or national trends based upon income levels, cultural, socioeconomic factors that may impact self-care access. Next slide, please. So these were the main findings in summary, and I'll just take you through the next couple of slides which walk through the main findings. There were lots of findings, of course. We collected a lot of information on mifepristone and misoprostol for medical abortion. It was quite difficult to formulate these into findings because the situation is so diverse, but I'm happy to respond to anybody offline on that. So the study was funded by WHO HRP, Sexual and Reproductive Health Unit, and we worked closely on this study with WHO colleagues led by Manjula Narasimhan. Next slide, please. So first of all, we looked at hormonal contraceptive products and whether or not they appeared in national essential medicines or formal OTC listings. And we found that the majority of countries have a national essential medicines list, as you would expect, which includes at least one hormonal contraceptive. However, in both Morocco and Nigeria, no reproductive health products are currently included in the national EML, despite the fact that multiple products are in the marketplace. The inclusion of hormonal contraceptives in published OTC listings or in other national databases varies widely and is somewhat inconsistent with their availability in practice. While many countries don't have a while many countries had a formal, while 11 countries had a formal OTC list, only 4 of those contained at least one hormonal contraceptive, and those were in Bangladesh, China, Ethiopia, and Lebanon. Overall, in all countries with or without official lists, emergency contraception is the most clearly defined OTC product, particularly those containing levonorgestrel. We also noticed in some countries that the formulations containing ulipristal acetate, i.e. the LA1 product, are more restricted than those containing levonorgestrel. So that was an interesting observation. Next slide, please. We also looked at the existence of formal processes and procedures within the regulatory body to switch products from prescription only to over-the-counter. So overall, 43%, in other words, 13 of the 30 countries sampled, have a formal regulatory process to apply for a movement from prescription only to over-the-counter. In countries which distinguish between the two classifications, the criteria for the OTC status is primarily based on safety and efficacy, risk assessment, and medical eligibility criteria. In high-income countries, where there are some quite sophisticated processes for this that have been put in place over a number of years, this may include pharmacy screening at the point of access. So it's really behind the counter rather than OTC. So we thought that was also an interesting finding, that something becoming available OTC was not necessarily taking away all barriers to access. If you then had to engage with the pharmacist and work through a long questionnaire before being provided with product access. And the specific criteria, ranges and designation and medicines differ from country to country. For diagnostics, it was good news. Most countries have procedures for the regulation of diagnostics, 10 of the 13 countries investigated. And in those countries, pregnancy and fertility tests are all classified as OTC low risk, while HPV self-tests are classified as one risk level higher, but still easily available. Next slide, please. So again, as I said at the beginning in the criteria for the research, we also tried to establish whether there were any linkages depending upon the economic status of the country in terms of formal regulatory and processes and procedures and the ability to see a pathway from switching from POM to OTC. And we noted that countries with stronger health systems and therefore by default probably stronger regulatory functions, rather than geographic location, are more likely to have distinctions between POM and OTC. And you can see that in high income countries, there was a formal process available in 83% of the surveyed countries. In upper middle income, that dropped to 62.5. For lower middle income, it was only 15.4. Next slide, please. So just a quick window into the countries that were researched within Africa. 8 countries in Africa were included in the review. You can see which countries they were on the slide. In Ethiopia and Kenya, there are clearly defined official procedures for changing category of medicines from POM to OTC. In Kenya, changing the legal status of a product is possible, but it involves the marketing authorization holder for the medicine submitting a variation to the national agency. And in Nigeria, Uganda, Zambia, and Zimbabwe, although there are well-established national regulatory agencies, there are no formal documented procedures to change products from POM to over-the-counter. However, in all of these countries, on a case-by-case basis, there is the possibility of making these changes. So, for example, in Cyana Press is available in some drug shops for self-administration in Uganda. Emergency contraception is available in pharmacies in Zambia. and also in Zimbabwe. So it's interesting that it doesn't necessarily mean that because there isn't a formal process that we can't that it's not possible. So in summary, in general terms, there is a significant lack of consistency across the 30 countries that we sampled. POM to OTC not allowed formally, but widespread availability regardless, which may have safety issue considerations. Some countries with well-defined formal processes with OTC lists, others without a pathway, but on a case-by-case basis, it's possible. And a number of countries, unfortunately, where product access directly for users remains challenging. Next slide, please. So quickly going through the conclusions from the research that national essential medicines list should consistently reflect and correlate with hormonal and RH products based upon the WHO list. Countries should consider adopting a formal regulatory process for the reclassification of medicines from POM to OTC in support of self-care. Standardization of procedures across countries would facilitate improved uptake. An interest in legal classification changes in relation to manufacturers. Countries should consider publishing a national OTC list, which is updated periodically, and that the development of a standardized risk-based model for safety and medical ability criteria countries would facilitate a consistent approach for reclassification. Last slide, please. So I'll leave you with some points to consider, and it really speaks to the issue as to whether or not regulatory is an enabler or a barrier to the self-care impetus. So our regulatory process is a positive attribute to support self-care, providing the confidence to users that a medicine is proven to be safe and effective for its intended purpose. Our regulatory process is a barrier to increased self-care through designating a medicine as provider dependent in terms of prescription-only access. And would the self-care agenda benefit from a defined and harmonized approach to regulation, allowing for the necessary processes to ensure safety, but also for ease of access over the counter from the outset? So thank you for listening. I'm happy to answer your questions in the chat. Thank you very much.
Thank you so much, Lester. This is a very great presentation showing us the context of regulatory, as well as supporting the first presentation that we just heard from Saumya. So I really want to maybe go back quickly to the chat where we have up to now 2 questions. And because of the time, I will ask you to use no more than 5 minutes to respond to them. The first one is from Amanda Livingstone, who asked, over the past few years, male birth control efforts have been ended due to men reporting side effects like acne, mood swing, and weight gain. All these things women have been experienced for decades and which are often pushed under the rug. How can this community continue to encourage men to try and maintain a men birth control regime like the gel referenced by Saumya and overcome this normal side effect? And the second question from Megan Christophil, I wonder whether Saumya could speak more about the most obstinate factor or challenges for introducing self-administrated technology device drug. What should advocates be watching for? So I know you may need more time, but if you can consider just 3 minutes for you and 2 minutes for Lester, that will be good. Thank you. Over to you.
Okay, thanks, Jeremy, Amanda, and Megan for these questions. So my response to Amanda is that, excuse me again, what you say is absolutely right, but I do think that that there has been a change in recent years, and it goes back to the point that I was saying about you have to understand consumer needs and meet them where they are. In many countries, for example, we are seeing that men are interested in contraception and having the autonomy over their own reproduction. So we are seeing that shift, and they may be willing to consider many different options. But of course, we'll have to address what their particular needs are in terms of preferences. Let me now turn to the question that Megan posed. And here I think there are three different ways one can look at this. One is to look at the policy and regulatory context, the particular issue that Lester was talking about when you move a product from POM to OTC status. If you look at the work that we did on emergency contraception in the 90s, typically ECPs were available only by prescription. Then over time, now they've become OTC in several places. And even if they are by prescription, oftentimes they are available at chemists in the countries that we work. In terms of what providers can do, the big challenge that I see in this space is providers feeling that their preeminent status in the caregiving process might change. And so we have to help them navigate that they're still important stakeholders in the caregiving process, that they have a role to play, except that the role might be different. And I think advocates have to be, and all of us have to be better at articulating what their new role would be. This could be supporting health consumers, learning more about new products. So I think that is a challenge that we will have to face. The third piece around consumers is orienting them towards new products, providing them with knowledge on how to use it. Increasingly, we are learning that consumers too, especially as a new generation of SRH consumers come on board, they are willing to try new products, products that their mothers and fathers didn't use. They're open to trying new things. It's almost like, what's the next new cell phone? So this is the same mentality that they're bringing to healthcare technologies too. The second sticking point that I would like to raise is with self-care products, we do have to be concerned about who's paying and who's paying how much out of pocket. Just having a product that's available doesn't mean it's necessarily at a price point that consumers can afford to pay, especially if it comes out of product. So, this is a bigger financing discussion. Thank you, Jeremy.
Thank you so much, Saumya, for your nice and comprehensive response. So we got additional questions straight for Lester. So I may ask Lester to respond to them. This question are one from Mary Jane on where are the pressure points for influencing global position on regulatory process for self-care product? Who is the right group to lead this? WHO? Are there any regional model we could consider for supporting countries to develop OTC regulatory process? And another one from Megan is Lester, does this lack of pathway from POMA to OTC mean you should be going straight to OTC for new product? So, there is another one you have. So if you can go straight, we have only 2 minutes, and I really appreciate if you can take on that. Thank you.
Sure, thank you, Jeremy. So for Mary Jane, yeah, it's an interesting one. I think the responsibility for normative standard setting in this area does belong to WHO. I think it needs movement by WHO in establishing and modifying guidelines and developing guidelines and processes for this to be put in place. Not least because at the country level, it is, the guidelines and standards from WHO are extremely well received and usually lead to some form of mobilization and action. I think it will be a challenge for everyone because, you know, regulation sort of by definition is somewhat conservative. So I think there is a forward challenge for us all to find, you know, ways in which we can ensure the safety of medicines and ensure that regulators play their right role, but at the same time we can better facilitate self-use. So I think the starting point is WHO, and we should also not forget the emerging harmonization initiatives that are taking place around the world, and the conversation should also move into some of these groups as well. In relation to Megan's question, so I don't think we skip the pathway, Megan. I think there's, you know, a responsibility for regulators to ensure medicine quality and safety, and to ensure that users have the information they need to administer properly. At the same time, we can improve for sure. You know, there should be a defined pathway to OTC. You know, for some products, it's already happening. So for leprosteal acetate, for example, approval in France for OTC was immediately accepted on a reliance basis by regulators in Morocco and Tunisia. So, you know, the change in France immediately increased access in Morocco and Tunisia. So there's lots of things that we can do, but we do need to resolve this issue because I think it's going to be really important going forward for the agenda. Thank you.
Thank you so much, Lester. Thank you so much, Saumya, for your great presentation. And that will conclude our first panel. So now we are going to move to the second one. And I would like for that to introduce the first moderator of this third panel, that is Dr. Catherine Kidiga. So Dr. Catherine Kidiga is work at Population Service International as a project lead for HIV/AIDS Self-Test Challenge Fund, whose main objective is to catalyze the market of HIV/AIDS self-testing. She received her master's degree in public health from the University of London School of Tropical Medicine and has 10 years of experience in designing, implementing, evaluating HIV/AIDS program in Kenya. So you are welcome, Catherine. If you allow me, I would also introduce the second moderator of the second panel that will be on lesson learned from self-injection subcutaneous DMPA. And this is Ebony Isi. Ebony Isi serves as the Deputy Director in Monitoring, Evaluation, and Learning Lead for the Access Collaborative at GSI. The Access Collaborative is a SIF and GATE-funded partnership between PAF and GSI. Ebony is a monitoring, evaluation, learning, and adaptive management specialist with nearly 10 years of experience improving global health and health system. She has a deep background in qualitative and mixed method research and has worked domestically and internationally in community-based participatory research and program design, implementation, and implementation. Please welcome Catherine and also Ebony. Catherine, over to you.
Thank you, Jeremy, for that wonderful introduction. So this is an exciting time for self-care. We have new technologies that are creating an opportunity for consumers to self-diagnose and to self-administer treatments together with prevention. It is my great honor today to be here discussing these issues. And I would like to also just go ahead and introduce to you our panelists. Our first speaker is Ramon Babamole. He is the project director for the National Youth Network for HIV/AIDS in Nigeria. This network comprises more than 100 youth-led organizations. Ramon is passionate about youth advocacy. He is currently the secretary of Lagos's State Technical Working Group on HIV prevention. He holds a BSc in both sociology and criminology. Kindly, Ramon, make your presentation.
Yeah, okay. Thank you very much, my able moderator. So thank you very much. So it is my pleasure to be here today. So I really want to appreciate the organization for the opportunity given to to Nigerian youth to add our voice into this, as in to add our voice into this program. So it is my pleasure being here. So, and I would like to move straight into the presentation. Can you move to the next slide, please? Hello. Okay, yeah. So I'll be sharing my thought around HIV self-testing. And as we all know, HIV self-testing is part of, formally we do have two models, which is the facility and the community-based model. But the advent of the technology that brought in HIV self-testing, which make it to be under the innovative. And what is innovative is going to do is to help, to help countries, including Nigeria, to actually reach their first 90. So we all know the 90 initiative by UNH. And for state, and which is the first 90 is the most important because of the role that it plays. Because without the first 90s, we won't be able to identify the people that are going to be on treatment, because the first 90 is talking about testing. It's through testing that we know the number of the people that are going to be on the treatment, and before we can talk about viral suppression. So I don't know if I'm communicating. Hello, is there everybody can hear me? Hello?
I can hear you. Go ahead.
Yeah, thank you very much. So the HIV self-testing share many characteristics with current HIV testing and counseling approach, which include product accuracy issue, linkage to care, potential benefit and risk, and regulatory policies and frameworks. So the HIV self-testing is just like the former testing. There's a guideline for it in Nigeria here, and I'm very sure that almost every other country that have adopted it also have their own guidelines. So although it might be vary from country to country and from region to region. So one of these basic things about this guideline is that it provides as in the mode of implementation. So for the self-testing too, so there is a platform for you to have access to information, counseling on how to do what, how to read the results, how to interpret the result, and also link you to care and support. So all of this is part of what, as in it is also embedded in the HIV self-testing implementation guideline in Nigeria, here in Nigeria. So next slide, I'll move into the next slide so that I'll be sharing the barriers and the benefit of it. So looking at the barriers of the HIV self-testing, so looking at the linkages and referral. So one of the major challenge, even from the traditional mode of testing, is linkage to services because of what? Self-deniers. You can have somebody that will tested positives, so it will just be what? Self-denier. The person might not want to accept the result as a that person. So if the person does not accept the result, so it will be very difficult to actually refer or to link that person up for treatment. So that is one of the major barriers. Then again, we talk about price of these services, because the part of the guideline here in Nigeria is that the HIV self-testing is not free. Although the government still support and we still make use of it in some of the community outreaches, then you can also find it in facility-based too. But you know, there are some other places that where you can actually procure these HIV self-testing kits yourself. So the price, once the price is too, if the price is too high, so it's going to affect more. And the reason why these innovations come about is just to ensure that it gives everybody access to what? Access to HIV/AIDS services. But if the price is something that is not affordable by the majority, especially the youth, like our country, that where the unemployment is very, very high in Nigeria. So when the price is too high, so it's going to affect people to access the product, and when people cannot access the product, that means the services is not not available. When the service is not available, and that might also hinder the country to actually reach its target of the first 90. And once the first 90 is not reached, so the second and the third 90, there must also be what? There is every possibility of that country not reaching the second and the third 90 when you cannot reach your first 90. Then user error and inability to read the result. Fine. So the way the HIV self-testing is being designed, So it will be very difficult for somebody that is not learned, the illiterate people, to actually make use of it, because you have to do it yourself. You go through the manual. So from the manual, so you'll be able to read some of information that it is needed for you. So it's from the manual that you get to know how to interpret the result. But if that person is not learned enough for him to be able to read and understand the information in the leaflet that is inside the test kit, so that person to actually, if the person tested positive, the person might be assuming that it's still negative. So that is one of the barriers. Then again, we talk about quality. Quality is very, very key. Yeah, so because now we are having different kind of product of HIV self-testing, different channels of distribution too. So it's something that in Nigeria here, you can buy online. So you can order for it online, it will deliver to you in your doorstep. But all these other products too, how are we sure about the quality? So how are we sure about the quality? Then the counsel is also one of the major, as in counsel is very, very key. Both the pre and the post-test counsel is also very. The HIV self contribute to the global target of 1990. I've already said that. The first-time tester, as well as what? By creating demand for and enabling more people to receive HIV testing, particularly those with undiagnosed HIV, or those people, more especially those in the what, out to reach community, the key population, the youth population, people in the riverine area too. So the HIV give them the benefit of them knowing their what, their HIV status. HIV self-testing has proved to be highly acceptable among various groups, including the youth, the key population. And this will make me to go back. Formally, the problem that we do have in the HIV/AIDS sector is the fact that, we have the problem of, healthcare providers not having the skill to provide youth-friendly HIV services, not having the skill to provide key population-friendly HIV. But HIV, the advent of HIV self-testing actually helps us to address some of these barriers in service provision. Ability as I've talked about how to reach communities and all of that, then it also help to reduce stigma and discrimination in the process of accessing services, ease of use with minimal waste. And so it's also helpful to do what? Thank you very much.
Thank you so much, Ramon. Now we'll listen to this video. Next slide, please.
A tiger? Updating your status on WhatsApp, Facebook, Snapchat? But do you know your status? Huh? No, not that status, your HIV status. Do you know that only 33.9% of Kenyans have gone for a HIV test? What if I told you that you could test yourself in the privacy of your own home? Yes, right here, right now. Introducing the HIV self-testing kit that allows you to live confidently by testing yourself easily and conveniently, anywhere and anytime. Now you can live confidently with the HIV self-testing kit and know your status in the privacy and comfort of your home. Available at select pharmacies. HIV-ST is a screening test. If you test positive, you must go for further testing at any health facility. For counseling and more information, call or SMS 1190 for free. WhatsApp 0700 121 121.
Thank you for that. We can move to the next slide as I introduce our next speaker. Our second speaker is Dr. Margaret Njenga. She is the Chief Operating Officer at Population Services Kenya. And the main mandate for PSK is getting HIV/ST into the hands of those who are hard to reach, such as the youth and men. Dr. Njenga holds a master's degree in public health and has also 10 years of experience implementing in these programs. She is a thought leader in the fields of HIV, TB, reproductive, and maternal child health. Go ahead, Dr. Margaret.
Thank you, Dr. Kidiga, and everyone else. I'd like to take you through a bit of the HIV self-testing. I believe the video that has just been shown tells all of us a little bit about HIV self-testing in Kenya. In Kenya, we have a number of approved self-testing kits, and this include both blood-based and also oral-based fluid kits. The HIV self-testing kits provides an opportunity for different subsegments of the population who are not currently reached by existing HIV testing services with information about their HIV status, and also gives an opportunity to contribute significantly so that everybody is able to know their status and with an objective of universal knowledge of HIV. Various channels are used towards getting these specific HIV kits to different populations. And in Kenya, that has a HIV prevalence of 4.9%, there's a huge testing gap among men who are aged 15 to 34 years, who contributes the highest number of the increasing HIV, the new HIV cases that are increasing in the country. So through a project run by Population Services Kenya, we have found ways of reaching this population that has not been tested often, unlike women who have various or specific touch points with the healthcare system. For example, women, and especially women of reproductive age, are able to access healthcare services at a very young age, and especially once they are sexually active, they are able to get reproductive health, either counseling services. Once they're expectant, they'll go for antenatal care, delivery, post-delivery, they'll take their children to immunization. So they have various touch points. But unlike men, most of the men do not have the privilege of visiting healthcare facilities, and most present when it's very, very late. So through a project funded by CIF to PSI, one of the things that the project has done is delivered the HIV self-testing kits directly to the hands of men. And this is through directly going to where the men are. For example, through workplaces where, and most men who are young and healthy, they're heavily found in various workplaces, including construction sites. Some of them are in security firms, manufacturing industries. And through the project, PS Kenya has been able to directly go to these workplaces and educate men on the importance of testing, and also deliver HIV self-testing kits in this specific population through innovative channels, including through use of vending machines that have ensured that men can get access to the kits privately, and also in an anonymous manner, and test themselves in the privacy of their homes. We've also reached out through community hotspots. This is through heavily populated areas, including marketplaces, bus stops, small-scale businesses, youth dens, where the youth hang out. These are various channels where we've been able to get to the men. And also through pharmacies. Pharmacies provide a unique channel for getting access to HIV self-testing kits, including walk-in pharmacies, through leveraging technology and utilizing online pharmacies that deliver kits directly to anyone who needs them. They're able to order online through MyDawa platform or through the Kasha platform. And these kits are delivered directly to the comfort of their home. So this, and especially during the COVID-19 outbreak, one of the things that happened globally and also in Kenya, there was it necessitated restriction of movement. And this really revealed the power of self-care because it ensured that kids and people, the population was able to access testing services, especially among the population with the highest ongoing risk for HIV infections. There was increased testing frequency, and there was the population was able to access these services through the various digital platforms that were availed. So once people get the kits, they are able to get their various ways of testing themselves. And should they need any assistance, they are able to get this through online sources, for example, through various self-demonstration videos. There are also messaging platforms. There's a toll-free number and even a WhatsApp for Business platform that really provides information on assistance on how they can get tested. And thereafter, should they turn negative, they get further information on how to continue staying negative. And for those who turn positive, they are linked for confirmatory testing and for further care and treatment to the closest health facilities. We also have demand creation campaigns that are increasing awareness on availability of this powerful self-testing platform that really brings self-care to the hands of each and every Kenyan. So thank you very much, and back to you, Dr. Catherine. Thank you.
Thank you, Dr. Margaret. We now have our final speaker, Zachariah Khawai, and he's the Managing Director of the Link Empowerment Initiative in Githurai, Nairobi. As a champion of change, his life mission is dedicated to delivering community health services. Over to you, Zachariah. Zachariah, are you on? Can give him a minute to come on.
Yes, he is currently connecting, and then we can give him the microphone.
All right.
Okay, Zachariah, if you're ready, you can begin your presentation.
Okay, thank you very much. I'm Zachariah Khawai from Nairobi, Kenya. Today I'm talking about the COVID-19 effects, the service delivery. The Link Empowerment Initiative, we have been working as an implementing partner with Population Service of Kenya in this process of HIV self-test kits. The main problem that we have been occurring in our locality, whereby you can't access people because as for now you can't do public gathering, and also when it comes to meeting points, there are those ultimatums that the government have posted. The other thing is that we at the Link Empowerment Initiative, we have come up with different skills and avenues how we can reach people in our locality, and also specifically in the self-care kit, whereby they can get the kit and at their convenient places, such as using border, and also creating avenues whereby people can come out and request kits online. So as for now, we are working hand in hand with local border organization, which is helping us to reach out to young people, especially men and people, at their hotspots, and also at their homes. So what we are doing as for now, we're making sure that we at the Link, we have peer educators who are trained, and also the peer educators, we are using them as an avenue to make sure that the services are delivered on time, and also making sure that also they get the proper skills and also information. So we at the Link, we have trained them on how to fight COVID, first of all, making sure that they protect themselves. And also, after delivering the kit, they make sure that the person who is taking the kit is wearing a mask, have sanitized, and everything. So the COVID-19 have affected us a lot. And as for now, we are working hand in hand with our local organizations to make sure that the people can access the services freely, and also can make sure that they get the services freely and easily. So the other thing is about reaching them. We have created a platform whereby we can reach people through WhatsApp. They can request the kit online, then we send the kit through a motorbike. So the kit can reach in a convenient place at the right time. So those are the avenues that we are making sure that people are accessing the services, and through that, the activities have been okay, and we are very pleased working with Population Service of Kenya in this avenue. Thank you.
Thank you, Zachariah, Dr. Margaret, and Ramon for that. I'll now hand back over the mic to Jeremy. Thank you.
Thank you so much, Catherine, and all the presenters for this great second panel. So now I think everyone deserves to have 5-minute break, but keep online, don't hang up. I think we were asking our team to help us with short break, and yeah, please remain in the meeting. Just mute your line and turn your video off. Everyone is already off. And if you have questions, continue to put them on the chat box and hold until we come back. We'll be back soon, just 5 minutes for people who want to run, to do anything, take coffee, water, feel free to do it and come back. So, yes. Do you mind playing music or video if you have any? Yeah.
All right, welcome back, everyone. Our 5-minute break is over and on to Ebony.
Thank you, Natalia. Welcome back. And I see that there was a lot of conversation in the chat even during the break. So I'm very excited by this conversation. So we first heard from Saumya and Lester as they spoke some about what it looks like to bring new products to the market and some regulatory considerations. Then we heard from 3 great presenters. We heard from Ramon, Margaret, and Zachariah about HIV self-testing. And now we're going to switch gears and hear from a few more speakers about a different type of self-care product. This is going to be DMPA SC, which is an injectable form of birth control. So we'll have a number of speakers, and I'll start with a quick introduction and allow them to introduce themselves. And then we'll have a panel where each speaker will be asked to respond to a question related to DMPA SC and the self-injection of DMPA SC. And again, we'll have questions coming in through the chat that we'll hold for our Q&A session that will follow this. This session is one that will include speakers who are speaking both English and French. So if you have not already, please click, there's either a globe or an option for interpretation at the bottom of your screen and select the language of your choice. It'll be important here, even though at this point the speakers have been speaking English, if you are an English speaker, to select English at this time. So that way you're able to hear the interpretation from French into English. So please do go ahead and take a moment to click the globe or click interpretation and choose a language if you do not have one selected already. Next slide. So our first speaker will be Alan Namagembe. Alan is a clinical epidemiologist and biostatistician with over 10 years of experience in research monitoring, evaluation, data management, and policy advocacy. She's currently working for PATH as Uganda's Deputy Project Director and Ebony lead on the DMPA SC Access Collaborative project. Alan, I'll give you 1 minute to just introduce yourself and the current status of DMPA SC and self-injection in Uganda.
Thank you, Bonnie. So for Uganda, DMPA self-injection is currently offered in the health facilities, both at the public and private, community level by the community health workers. And we recently also had approval for it to be provided for by drug shop staff. Data from 4 districts which participated in the pilot between the period of Feb 2020 and March 2021, we saw 2,523 visits getting self-injection of DMPSC from the provider. Thank you.
Thanks for that overview, Alan. Next, I'll introduce Frehiwot Birhanu. Frehiwot is a senior public health expert with over 15 years of experience in sub-Saharan Africa in areas of sexual and reproductive health, human and institutional capacity building, and program development and management. She is currently working with the Clinton Health Access Initiative, or CHI, Malawi Country Office as a senior program manager leading SRMNH portfolio. Frehiwot, I'll give you 1 minute to introduce yourself and the status of self-injection of DMPA SC in Malawi.
Thank you so much, Ebony, for the introduction. In Malawi, DMPSC was introduced in 2018, including self-injection. And the introduction was a phased approach, but later we were able to scale up into all the districts of Malawi. And currently, the service is being provided in health facilities and community outlets through community health workers. Currently, all family planning service delivery facilities provide DMPSC self-injection. Just also to highlight some data, between January 2020 and March 2021, we have over 247,000 self-injection visits in all districts of Malawi. Thank you so much.
Awesome, thank you. Next, I'll introduce Yaba Asin with Japaigo Togo is a public health midwife who joined Jipaigo Togo in 2019 as DMPA SC Program Officer, then Country Program Manager. In this capacity, she's contributed to the strengthening of providers and the introduction and scale-up of DMPA SC, including self-injection. Yaba, I'll give you 1 minute to introduce yourself and the current status of self-injection in Togo.
Merci beaucoup. Au Togo, l'introduction du DMPA-SC a été faite depuis décembre 2018 à travers les agents de santé communautaire, mais de 2019 jusqu'à présent, avec l'appui du projet Accélérer l'accès au DMPA dans les pays du partenariat de Ouagadougou, le DMPA a été introduit dans les formations sanitaires, y compris l'auto-ingestion. Donc, à ce jour, toutes les formations sanitaires publiques offrent le DMPA-SC, y compris l'auto-ingestion. 49% des formations sanitaires privées également offrent le DMPA-SC et l'auto-ingestion. Les ASC n'offrent pas encore l'auto-ingestion, mais sur 49 districts sanitaires, 29 disposent d'ASC qui offrent le DMPA-SC. L'introduction dans les pharmacies a démarré l'année passée un peu lentement, mais ça va prendre un volet cette fois-ci. Et nous avons plus de 12 000 visites en auto-ingestion du DMPA-SC de janvier 2020 à mars 2021. Je vous remercie.
Thank you, Yaba. Next, I'll introduce Bibiche Kwanzimi from Pathfinder. Bibiche is a medical doctor with a master's degree in family medicine. She's Pathfinder International's country coordinator for the DMPA-SC Scale-Up Monitoring Project in DRC since 2019. Bibiche, I'll give you 1 minute to introduce yourself and to introduce the current status of the self-injection of DMPA-SC and DRC.
Merci beaucoup, Ebony. Je suis heureuse de faire partie de ces webinaires aujourd'hui. Je suis Bibiche Izale de Pathfinder. Le travail que je vais vous présenter sur que la RDC a réalisé sur la mise à échelle du DMPA sous-cutané et de l'auto-injection, c'est un travail réalisé avec l'appui des fonds d'opportunités catalytiques gérés par CHAI dans le cadre de l'Access collaborative et sous les parrainages de PAF. Alors, j'avais fait une présentation de 7 minutes. Maintenant, je cherche rapidement l'état de l'auto-injection. Le DMPA sous-cutané a été homologué en 2014 en RDC. Il a bénéficié d'une série d'études pour tester l'acceptabilité, la faisabilité. Et finalement, nous avons obtenu l'autorisation des mises sur marché en 2016. En 2018, le pays a développé un plan de mise à échelle du DMPA sous-cutané qui soulignait déjà un des avantages du DMPA sous-cutané, donc celui d'avoir la possibilité d'être administré en auto-injection par les utilisatrices elles-mêmes. Alors, le pays a développé en janvier 2020 les guides de mise en œuvre progressive de l'auto-injection, suivi de la formation au niveau du pool national, des formations d'un pool national des formateurs. Et ensuite, il y a eu formation en cascade au niveau provincial et au niveau des zones de santé, avec les cadres des zones de santé et les prestataires. Et nous avons aussi installé les sites sentinelles pour la collecte des données de l'auto-injection dans 58 formations sanitaires des 9 zones de santé de Kinshasa. C'est parce que les pays n'avaient pas encore intégré les indicateurs de l'auto-injection dans les systèmes d'information nationale. Le pays a élaboré après les guides de l'offre des services de planification familiale dans le contexte de la pandémie à COVID-19 qui avait déjà préconisé des recommandations pour recourir à l'auto-injection. Après, le secrétaire général à la santé a signé...
we're going to have some time. I know that you're looking for your slides, and so those will come up in just a moment. And so I'll pause you there and thank you for that introduction and that overview, and then we'll have your slides come up when we get into a little more of the panel. Is that okay?
Okay.
Oh, perfect. Okay, so our final speaker will be Laminou Aichatou with Pathfinder. Aichatou joined Pathfinder in 2020 to manage the pilot project on expanding contraceptive access in Niger through self-administration of DMPA-SC. Her program experience includes working with Help, Helen Keller International, Maurice Stokes, in state institutions in various positions of responsibility. Aichatou, why don't you begin with a 1-minute introduction?
Okay, thanks, Ebony. I'm Aichatou from Pathfinder, Niger. The DMPA-SC was approved in Niger in July 2009, and it was introduced and made available to all levels of the health system and for self-administration. As opportunity, we have favorable data from pilot experience lead to many implementing organizations and donors supporting Niger in scaling up self-administration. The main threats to scaling up are socio-political instability and insecurity, and lack of financial resources. Thank you, Ebony.
Awesome. So we have a panel of 5 incredible speakers from 5 different countries, ready to share with us their experiences introducing self-injection in DMPA-SC. So the first question will go to Alan in Uganda. So Alan, what is one key challenge that you have confronted in the introduction or scale-up of self-injection in Uganda? And could you describe a solution or innovation that you've implemented to address it? And we can go to the next slide for Alan.
Okay. Thank you, Ebony. On this slide, I'm going to talk about a challenge integrating DMPA-SC self-injection into HMIS. So on this slide, you can see 3 different challenges related to HMIS integration and 3 potential considerations to address these challenges. First, it is important to note that updating routine HMIS with new indicators can take a long time. So early and clear planning for potential integration should happen from the beginning. And also it should help to ensure that the product or practice introduction efforts can align with the regular HMIS update schedule. The integration for us, but the Ministry of Health leaders and providers has been even more challenging. Second, related to the above, even with early planning, the timing of regular updates may not align with the needs of the product or practice introduction and scale-up efforts. So one should prioritize simple interim approaches to collect critical data and link with existing systems to help lay a foundation for integration down the road and for sustainability. The data we showed during the introduction is coming from such a system. Finally, we want to know that HMIS data might not answer all questions. That is why we also talk about evaluation needs for introduction and scale up. So in addition to conducting standalone evaluations, we can also look at leveraging additional data sources for broader learning needs if we have key questions that go beyond routine monitoring and with limited funding. For example, we have worked with the PMA initiative to integrate DMPA-SC and self-injection in their survey as an additional data source as we wait for routine data to come through. On this slide, I want to go through how we are using self-injection data in Uganda. And first, we are using it to inform data-driven quantification and program planning to manage national and global supply variations. We are also collecting and reviewing data from the pilot districts, which has helped highlight implementation challenges like stockouts of the materials needed by clients for independent self-injection, what to do when they come back for resupplies, and which topics should be considered. We are also using this data to track progress on self-injection scale-up and also critically review its contribution on the method mix. In conclusion, integrating self-care practices in HMIS might be challenging and might take time, but it is beneficial for understanding how best to support clients who are taking up the self-care options. Thank you.
Well, thank you for that and those lessons on HMIS integration and scale up in Uganda. The next question will go to Frehiwot. Can you share one key lesson from building country capacity in DMPA-SC self-injection in Malawi? And you'll have just about 3 or 4 minutes to answer that question for us.
Thank you so much, Ebony. So I will be talking about one of the key lessons that we learned in the rollout of the DMPA in Malawi, which later led to the success of the national rollout. So as we roll out the DMPA implementation, including self-injection in the first phase 1 districts, we noticed that many of the DMPA users are choosing provider administration while there is the option of self-injection. So as we try to investigate during our supervision and mentorship visits, we understood and we learned that this is somehow related to provider reluctance. So as a background, when a woman is going to a facility needing family planning service, they usually receive a group health talk by a family planning provider about family planning in general, its benefits, and also individual methods that are available in that specific facility. So usually the number of women ranges between 50 to 150 based on the, depending on the size of the facility. So when the DMPA was introduced, it was incorporated into this health talk. So every woman coming to the facility, can receive a message about the DMPA. And if a woman is interested on the DMPA, including self-injection, then the woman will receive a one-on-one counseling from the provider in a deeper way, and also she will receive training on how to self-inject herself, including, teaching her about calculation of the injection dates. So the challenge that we observed was, as providers try to counsel the woman, provide that one-to-one counseling to the woman and train them on self-injection, it required more time than doing the provider administration. So normally, if a provider wants to administer an injection, she might need 10 to 15 minutes to do it. But to teach on self-injection and provide that deeper counseling until a woman is comfortable to do the self-injection herself, she might need up to 40 minutes. And as we can assume, these providers have a lot of women waiting for them, for their services outside. So they felt overwhelmed to spend that amount of time, that 40 minutes or more on one person. So, the quality of the counseling was being compromised, and more women were choosing provider administration instead of self-injection. So as a solution, the Ministry of Health with its partners came up with a strategy to include more information on that group health talk. So initially a lighter information was being provided during that general health talk. But if we incorporate detailed information somehow, not very detailed, but at least basic information about self-injection, walking the women through the key steps of doing the self-injection themselves, and also answering some commonly raised questions about self-injection, then we can take down the amount of time that a healthcare worker is required to spend teaching the woman during the one-to-one sessions. So as a result, this really actually brought a lot of impact on the overall quality of the counseling and the service that was being provided for the woman. So, since now the woman is coming with a better understanding of self-injection from the general health talk, then the provider is spending that one-to-one counseling to focus on key critical aspects of self-injection, and also, teaching the actual self-injection skills for the woman and addressing her other needs. So that cut down the amount of time significantly. And also it also improved the workflow. That means, the woman, the healthcare worker can spend the rest of her time, taking care of other clients that are waiting for her outside. So that helped us as in general as a program to pick up the self-injection rates from the lower levels that were there around 5-6% into 43% at some point. In addition to this strategy, we also tried to emphasize the benefit of self-injection for the provider. And as a long term, you might not see it right now as a provider, but if you spend those 40 minutes on a woman teaching self-injection, then she's not going to come back for the coming 12 months requiring your service. That means you will have less and less clients requiring injection, which in turn will reduce the workload. So emphasizing that message through mentorship and supervision visits also helped to change the mindset of the providers so that they can focus their time providing quality counseling. Thank you so much. Over to you, Ebony.
Thank you for that explanation. I think that it's incredible to hear about the ways that self-care and self-injection can impact even what's happening in at the clinic and the health facility level. So I appreciate you giving us that overview of how you all address some provider reluctance there. Our next question will go to Yaba, so we can go to the next slide. What is one factor that has facilitated learning of the self-injection technique among clients in Togo? And you'll have 3 or 4 minutes to answer that question. Yaba.
Ok, merci beaucoup. Celle que nous avons fait former à l'auto-ingestion chez nous au Togo, notre plus grande leçon, d'abord, c'est la disponibilité du personnel de service à accompagner les clientes pour l'auto-ingestion. Alors, ce personnel a été orienté, non formé, orienté à travers plusieurs approches pour pouvoir étendre rapidement l'offre de l'auto-ingestion sur toute l'étendue du territoire. Donc, ce personnel s'est rendu disponible pour accompagner, quel que soit le temps qu'il le faut, les clients à s'auto-injecter. L'autre chose, c'est l'utilisation des supports de communication, notamment la vidéo sur l'auto-ingestion de PAF et GS Child, que nous avons traduite en 2 langues locales, les langues les plus parlées au Togo, que nous mettons à la disposition de ces clientes qui disposent pour la plupart aujourd'hui des Android et communiquent à travers le réseau WhatsApp. L'autre chose également, c'est que nous avions élaboré, je crois que la slide qui suit, c'est ça qui montre la photo du dépliant que nous avons adapté ici au Togo pour remettre aux clientes qui s'auto-injectent. En plus de cela, à travers le réseau WhatsApp, ces clientes sont de plus en plus suivies par les prestataires. Donc, celles qui ont été formées, séances tenantes sous la supervision des prestataires, une fois à la maison, elles continuent par communiquer avec les prestataires de services si elles ont des difficultés par rapport au rendez-vous ou bien par rapport à toutes les questions qu'elles voudraient, et elles communiquent directement avec les prestataires de services qui les suivent de façon très rapprochée et qui sont vraiment disponibles. Des fois, pour l'ingestion à la maison, quand elles commencent, elles envoient des photos et des vidéos aux prestataires pour qu'elles regardent si elles ont vraiment respecté toutes les étapes. Et sans oublier également les directives de l'auto-ingestion que le pays a élaborées dès l'introduction du DMPA-SC pour expliquer comment cela va se passer. Ces directives sont bien claires et on explique également cela aux prestataires. Les prestataires les communiquent également aux clientes. Donc, si je dois retenir quelque chose par rapport aux facteurs qui ont favorisé la maîtrise de l'auto-ingestion par les clientes qui s'auto-injectent aujourd'hui, c'est d'abord la disponibilité des prestataires, ensuite l'utilisation des supports de communication et les dépliants qu'on remet aux clientes pour qu'elles puissent regarder de temps en temps, même pour celles qui n'ont pas été à l'école avec les images, elles peuvent également se rappeler de ces étapes-là et ensuite le suivi rapproché à travers le réseau WhatsApp. Ceci nous a permis de tirer cette leçon que les réseaux sociaux ne sont pas juste pour nos communications, envoyer des vidéos, mais c'est également un canal d'apprentissage. Voilà un peu résumé ce que l'expérience que le Togo a vécu. Merci.
Thank you, Yaba, for that answer. You know, if you talk about self-care, we often focus on just clients, but your response did highlight the importance of readying personnel and readying, you know, the media environment in order to really enable self-care to scale up and to thrive in a number of contexts. The next question is for you, Bibiche. Can you share some experiences and lessons from building country capacity in DMPA-SC self-injection in DRC? And we can go to the next slide.
Merci beaucoup, Ebony. Alors, ce que nous avons eu à utiliser pour approche pour l'expansion de l'auto-injection du DMPA sous-cutané comprend premièrement les réunions des plaidoyers pour des réunions qui se sont tenues autour du Programme national de la santé de la reproduction et la direction santé, famille et groupes spécifiques et les autres partenaires d'implémentation pour partager la compréhension autour de cette innovation et emmener l'autorité à émettre une autorisation officielle pour l'offre de l'auto-injection du DMPA sous-cutané. Nous avons aussi développé les guides de mise en œuvre progressive de l'auto-injection pour encadrer et orienter la pratique de l'auto-injection. Ensuite, nous avons lancé des formations en cascade au niveau national avec le PNSR et experts des autres partenaires d'implémentation au niveau provincial avec la division toutes les divisions provinciales de santé concernées et la coordination du Programme national de la santé de la reproduction. Ensuite, au niveau des zones de santé avec les cadres de la zone de santé et les prestataires. Ensuite, cette formation a aussi continué par les prestataires pour l'orientation des clientes elles-mêmes de façon à ce qu'elles soient capables de s'auto-injecter. Nous avons conduit des supervisions, des suivis et supervisions dans les zones de santé, dans un échantillon des zones de santé pour vérifier l'effectivité, l'efficacité de la formation, évaluer les connaissances et les compétences des prestataires en auto-injection du DMPA sous-cutané et aussi l'installation des sites sentinelles dans 58 formations sanitaires des 9 zones de santé de la province de Kinshasa pour assurer la remontée partielle des données en vue de renseigner les décisions, donc voir l'évolution, suivre l'évolution et renseigner aussi les décisions. Tout ça, c'est parce que au niveau du pays, on n'avait pas encore introduit ou intégré les indicateurs de l'auto-injection dans les systèmes nationaux de l'information sanitaire. Alors, comme résultat de tout ce que nous avons fait, nous avons formé 25 formateurs des formateurs au niveau national, 115 au niveau provincial dans les 13 provinces des 26, donc 13 des 26 provinces. Et ensuite, 1298 cadres des zones de santé et 4212 prestataires, dont 245 sur les 519 zones de santé. L'échantillon sélectionné pour la supervision, c'était des visites dans 47 zones de santé. Et depuis les mois de décembre jusqu'au mois de mars, nous avons dénombré dans les sites sentinelles 987 visites de l'auto-injection sur 3063 visites pour tous les DMPA sous-cutanés, donc auto-injectés et administrés par les prestataires, donc 32%. Dia suivante. Next slide. Alors, en ce qui concerne les défis, nous avons été retardés dans l'exécution des activités à cause du confinement et la suspension des vols comme la formation devait se faire dans 13 provinces. Dans un premier temps, il n'y avait pas possibilité de voyager. Et il y avait aussi une disponibilité limitée des acteurs, certains acteurs du ministère, vu que le travail devait se faire plus en ligne qu'en présentiel. Et les ruptures massives des stocks de DMPA sous-cutanés ont constitué vraiment une sérieuse entrave à la bonne marche des formations, comme il y avait très peu de stocks pour les exercices pour les prestataires pendant la formation. Le fait que les indicateurs du DMPA sous-cutané ne soient pas encore intégrés dans les systèmes nationaux d'information sanitaire ne nous a pas permis de percevoir les résultats de toutes les formations conduites. Alors, comme leçon apprises, premièrement, le plaidoyer nous a permis d'éliminer quelques résistances rencontrées lors des formations et lors des supervisions. Et puis, la modification des approches des formations intégrant des solutions techniques qui n'étaient peut-être pas encore perçues comme réalisables avant la pandémie 19 a grandement facilité l'obtention des résultats dans le cadre de cet investissement. La RDC a utilisé avec succès la formation en ligne pour transmettre les connaissances et les compétences aux cadres provinciaux qui ont ensuite assuré les restes de la cascade. Ici, je souligne l'utilisation des vidéos rendues disponibles par GSI et PAF. La disponibilité du DMPA sous-cutané est essentielle pour fournir une formation efficace sur l'auto-injection. Une autre leçon apprise, c'est l'intégration des informations sur l'auto-injection du DMPA sous-cutané dans l'outil de supervision harmonisée du PNSR. Ceci a représenté une opportunité car elle a permis aux acteurs de mieux comprendre et d'évaluer cette approche de l'auto-injection. Merci beaucoup. Thank you.
Thank you for that. I'm hearing some themes, we're hearing again around challenges with HMIS integration and understanding how that can impact self-injection, creating an environment. And here we heard something that I know a lot of us experienced, which was managing projects and family planning through the pandemic. Thank you for that. I thank everyone also for sending in questions. So we'll have one more speaker before we transition over to our Q&A. So please do continue to put your questions in the chat box. And this question is for you, Aichatou. Can you tell us about the acceptability of DMPA SC and self-injection among clients in Niger? Anything around discontinuation or main reasons for women dropping out of self-injection? We can go to the next slide. And you'll have 3 or 4 minutes just to give us a response to those questions. Thank you.
Ok, merci beaucoup, Ebony. Donc là, moi, je vais vous présenter les données d'une étude qui a été conduite par Pathfinder avec l'appui financier de l'UNFPA et en collaboration avec le ministère de la Santé du Niger. Donc, cette étude porte sur l'élargissement de la pratique contraceptive au Niger à travers l'auto-administration du DMPA sous-cutané. Donc, à travers cette diapositive, nous avons les résultats de l'acceptabilité de cette approche, donc de cette pratique par les femmes au Niger. Donc, nous voyons 5 groupes d'histogrammes. Donc, le premier groupe, il s'agit du nombre de femmes qui ont accepté qui répondent aux critères et qui ont accepté de s'auto-injecter le produit. Donc, le second groupe, donc, il s'agit des femmes qui ont été touchées au premier cycle d'auto-injection. Donc, en troisième groupe, il s'agit des femmes qui ont été touchées par le second cycle d'auto-injection. Ensuite, nous avons celles qui ont été touchées au troisième cycle d'auto-injection. Et puis, enfin, celles qui ont abandonné, donc le nombre de femmes qui ont abandonné le programme pendant l'étude. Donc, nous remarquons qu'au début, nous avons enregistré jusqu'à 156 femmes. Donc, cette étude a été réalisée dans 2 régions, donc à Niamey et à Tilaberi. Donc, pour les 2 régions, nous avons enregistré 156 femmes qui ont été suivies pendant 3 cycles. Donc, au second cycle, nous avons malheureusement continué avec 139 femmes puisque nous avons enregistré 17 femmes qui ont quitté le programme. Diapositive, s'il vous plaît. Ok, merci. Donc là, sur cette diapositive, nous avons les informations sur la maîtrise de la technique d'auto-administration par région et également par cycle d'auto-administration. Donc, en orange foncé, nous avons les données de la région de Niamey et en orange clair, ce sont celles de la région de Tilaberi. Effectivement, avant qu'elles ne s'auto-administrent le produit, ces femmes font des essais. Donc, pour le premier cycle, nous remarquons que nous avons seulement 10% des femmes de la région de Niamey qui ont réussi au premier essai. Donc, elles se sont fait auto-injecter le produit juste après. Donc, au niveau du second cycle, nous remarquons que là, il y a un changement. Nous avons pour le premier essai, dès le premier essai, nous avons jusqu'à 42% des femmes de la région de Niamey et 28% de celles de Tilaberi qui ont réussi le premier essai. Maintenant, puisque l'essai est concluant, elles passent à l'auto-administration. Donc, il y a celles qui ont, entre elles, fait le second jusqu'au troisième essai. Maintenant, nous remarquons que pour le troisième cycle, là, nous avons également jusqu'à 55% au niveau de Niamey et 44% au niveau de Tilaberi qui ont réussi l'essai de qui ont réussi l'auto-injection de le premier essai. Et seulement une femme au niveau de Tilaberi a passé au second essai. Donc, sur les 139 femmes qui ont continué donc du second cycle au troisième cycle, nous remarquons que juste une seule donc n'a pas pu s'auto-injecter le produit de le premier essai. Donc, merci beaucoup, Ebony. Je suis à la fin de ma présentation.
Thank you so much for these presentations. We got a chance to understand a fair amount of the challenges and innovative solutions that a number of our implementing partners in the Ministry of Health have instituted in order to support the scale up of self-care through the self-injection of DMPA-SC. With that, I'm going to hand it back over to Jeremy, who will help us to facilitate the question and answer session. Dr. Jeremy?
Thank you so much, Ebony. Thank you all the presenters from the 2 panels. It has been very great. I think we are gathering questions from the chat box, but what we will be also able to do is probably to allow people to off-mute their mic and maybe raise their question first if they have critical question and comment. And we will allow few people to just, ask question, comment. And while also answering some of the questions on the chat box, we'll be targeting few presenters who will be able to, to answer and also respond to some of the questions. So if somebody wants a comment or question, feel free and feel free to raise your hand, and you can have the floor to discuss. But in the meantime, I will be reading some of the questions in the chat and see how we can respond, address them. And I think I am trying to see how I can have access to the list of questions. Yeah, I'm not seeing yet a name, but I will start picking some of the questions. Somebody asked when Ramon was making presentation on self-testing, a question was, what are the obstacles of free testing in certain areas? This was asked by Yaba. So if Ramon is online, he can just step in and respond to that. Then we'll, under the HIV/AIDS self-testing also, there is a question to Maggie. What strategy do you use while distributing the HIV/AIDS testing kit to different age category? So for example, if an adolescent needs these HRS services, there are chances of them getting stigmatized because they won't feel comfortable due to fear of being judged. Are the kit supply of free, or do you have a certain criteria that you base on who gets it free and who will need to purchase it? So if I can get Maggie and Ramon to respond on the HIV/AIDS side, then we'll move to the DMPA family planning. And if we have time, we can come back. And also we'll be happy to take anybody who raised the hand. So can we start with Ramon if you are online?
Yes, ma'am.
Ramon is not online apparently.
That I've not been able to operate. That I've not been able to operate it.
Can we mute? Somebody is talking. Ramon?
Ramon is talking. Ramon, can you move closer to the microphone?
Okay. Okay, I want to respond to the question that was asked about as in the areas, so the challenges. So basically, in some of the areas here in Nigeria where we are having as a challenge as regards to implementation of HIV self-testing, has to do with rural communities where you have more people that are illiterate, that are not learned, because the way the HIV self-test kit is being designed is the fact that if you are not learned, you will not be able to, read some of the directives, some of the leaflets. So for instance, you might not be able to be able to interpret the results after the test as well. So although there is a videos that you need to watch, and you also need to look at, video that maybe there's a link where you can, we share videos when we are trying to implement it in the rural areas where they can watch the videos. But at times you also see have network issues. So that's the only areas where we are having challenge. But in the urban area, so it is well acceptable in the urban area. Then another question that I also talk about the different groups that as in criteria that we use to distribute to the different groups. So basically, so the most target groups were the youth populations, because like Nigeria is a youth country. So looking at the population of the country, so the youth cover about 65% of the total population of Nigeria. So the country is a youth country, so we give more priorities to youth. So our outreaches when we are going to school or community where we know that we have more youth, so we always make it available for them to complement the normal traditional testing that we do provided at the community level. So we make the HIV self-testing to also be available, and we make it free for them, for the youth populations. So thank you. I don't know if I've actually answered your questions.
Okay, good. Thank you so much. Can Maggie come on and also answer these two questions? Thank you,
What are the questions?
No, I'm now referring to Maggie. Thank you, Ramon, for your answer. I want to allow Maggie if she can also respond to some of them.
Sure. Thank you, Dr. Jeremy, and thank you all for the questions on HIV self-testing. So to the first question on whether the kits are free or not, so there are various categories. There's free distribution to the very vulnerable population, and also there's another category of kits that are not free, that are distributed or rather sold through both online pharmacies and also walk-in pharmacies. There was also a question on sustainability for the kits that are distributed for free. So under the kits that are distributed for free, one of the things that we do is work with various partners, including the Ministry of Health. We also have private sector partners, including manufacturers and distributors. So what essentially we are doing is that we are creating, we are working towards catalyzing the market towards production of HIV self-testing kits and ensuring that there is high demand and supply through working with the various stakeholders. This is going to take a number of years. However, we have seen some progress. We have behavior change communication campaigns to increase awareness and also to increase demand for the HIV self-testing kits. And with increased demand, more manufacturers would be willing to put in resources towards production of HIV self-testing kits as long as they are assured of a market. There was another question on stigma for during distribution for the various self-testing kits. Indeed, stigma remains a big barrier, especially in urban populations. Unlike the rural populations where we are seeing stigma has reduced to a certain level, heavily because of the amount of work that has gone in, the resources, the partners who have put in resources towards encouraging those who are positive to come out. In urban areas, we are seeing that the stigma is significantly higher, and indeed, it remains a barrier. However, through this channel of utilization of self-testing kits, it gives an opportunity for those who still feel stigmatized. It gives them an opportunity to get the kits at the privacy of their homes. They can order online and the kit is delivered themselves, and it gives people an opportunity towards knowing their HIV status discreetly. There are also various champions who have come out towards, and including media personalities talking about their HIV positive status. So this is also contributing towards a reduction of stigma. However, indeed, it still remains a barrier. Thank you.
Thank you so much. Can you maybe quickly respond to one question before we move to the DMPA? That question was any practices on how they have strengthening documentation of outcome following HIV/AIDS self-testing. For example, number of clients tested via HIV/AIDS self-testing, number of turned positive, number of linked to confirmatory diagnosis and subsequent into care. Do you have like something quickly? If not, it is fine.
Sure, I can proceed, Dr. Jeremy. Thank you, Joram, for that question. HIV self-testing, based on your questions on the data, documentation, the number of clients who are tested. One of the challenges we are seeing in HIV self-testing is that this is a new area, and most throughout the ministry, we do not have strong data collection tools towards ensuring that the kits that are distributed are reported. However, we have proxy indicators towards measuring or knowing how many kits have been distributed out there. So what we use, or rather what is being used in the country, includes the number of kits that have been purchased. And this within the private sector, we are able to get this data primarily from the distributors, and also where we distribute directly to pharmacies, we get the pharmacies to report back through various channels that we have developed, including using mobile phones, using a USSD code to report back on the number of kits that have been distributed. We have various linkage channels that tell us who has turned positive. And this include a WhatsApp for Business platform that is utilized so that once a client utilizes a kit, on top of the kit, there's a sticker that has a number where they can directly report. There's also a toll-free number that they can call, or they can send an SMS. However, this is dependent on the user's preference towards reporting their results. It's heavily linked to that because of the design of the self-testing kits. Users do not necessarily have to report their results. However, we have seen some progress, and in the project that we're running at the moment, up to 45% of those who have received the self-testing kits have reported back on their test result status. In case of any further questions, do feel free to reach out to me. Thank you. Back to you, Jeremy.
Thank you so much, for your answer. I do believe that we can proceed with the next topic that is on DMPA. And I would like to maybe start with a question from Elizabeth Smith to Ellen. In Uganda, can women access DMPA SC for self-injection in drug shop nationwide or just in certain districts? Do the drug shop have to be accredited by authorities? So if you can, I think Elizabeth responded that I wasn't able to read, but there was some response. Hello, is Elizabeth?
Very quickly.
Yes.
Very quickly, I just punched in a response saying yes, the approval for drug shops to provide DMPS self-injection is nationwide, but it is very recent, and scale up is really very early in its stages. So not many districts have their drug shop staff trained, but that is happening. And regarding accreditation, yes, we're working with only accredited drug shops because they have to get the free commodity from the national warehouses, and then they only charge a minimal fee. That's why they have to be accredited. Thank you. Over.
Thank you. So there is another two questions on Malawi. How did they integrate more information? What type of additional information did they add? And were there any educational aid? And they also want to know if there was any confidentiality issue. I think as Frehiwot from Malawi is the one to respond to that.
Thank you, Jeremy. Thank you for the questions, Barbara and Jong. The way the message is being incorporated is normally a healthcare provider has a kind of a pretty standard message in their own facility. You know, they will pass to clients every day regarding family planning. So it talks about the general benefits of family planning and the methods they have in the facility. So the additional information that was incorporated during that group health talk was what the DMPA self-injection, specifically, it being a new method that allows women to inject themselves. The added advantage of having, injecting themselves, to say they are not required to come to a health facility frequently. They can do the injection themselves at home because they will be sent with additional doses. That the healthcare worker will ensure that they are competent to do the injection, because from the counseling experience so far, women are a bit afraid and not confident that they will not be able to inject themselves properly. So the healthcare provider addresses that question during the health talk. And also, the needle is a bit smaller than the normal needle they know that the healthcare worker uses to inject them. So all this information is added. And in addition, the healthcare worker also uses a leaflet, which is a kind of an illustrative picture that shows the step-by-step process of DMPA self-injection. So they will just walk them through the steps they will follow to activate the reject, to identify the area they will do the injection, and how to do the injection. So this is the message that's incorporated in the group health talk. For the second question regarding confidentiality, so the group talk it's not it's not a deeper counseling. They are just passing those messages that I highlighted earlier. But as a standard practice, women, healthcare workers recommend women to keep any sensitive questions or concerns they have to the one-to-one counseling, so that they can attend them in private. That's the message they share. So far from our visits and also our interactions with healthcare workers, I don't remember anything critical that was a big issue, but I assume healthcare workers might encounter some of this information. But in general, that's the message that we share with healthcare workers, and also healthcare workers share with the clients. There was one question about integration of DHIS2 from Blami. So in Malawi, DMPA is integrated in DHIS2, and also we track self-induction through the DHIS2. Thank you so much. Over to you, Jeremy.
Thank you. I would like even other people to respond on the chat if they have been integrating mobile data collection so that we know which country. Even from participant, it will be good. But also there is another question, this question is from Professor Laminou, so you can answer directly in the chat. And one question from Saumya is, how do we change the mindset among all stakeholders, including health consumer, that user can be trusted to use product and practice self-care behavior? What kind of intervention or practice example do you need to generate to change this mind? I will recommend, the next person can respond to that, but I will recommend you guys to type your answer in the chat box. That will be very useful so that we can put them together and share with the rest of the team. So to not be biased, I would like to offer one francophone to answer. What are the side effects of the product? I think it is the DMPA product after injection of this product, or how long can a woman receive it? I may go, I think it's to Yaba, I do believe. Quels sont les effets secondaires de ce produit et après injection de ce produit? Après combien de temps que sa femme peut de nouveau concevoir? So this was a kind of translation.
Merci beaucoup.
So if Yaba can answer, that will be good.
Ok, merci beaucoup pour la question. Pour ce qui concerne la durée de la survenue des effets secondaires après une ingestion, ça dépend de chaque organisme, mais ça peut apparaître dès la 24e heure, dès la 24e heure, et puis ça dépend de chaque organisme. Et pour le retour à la fertilité après les injections de Sayana Press, je pense que ça doit être similaire au dépôt Provera, où il est noté un retour lent à la fertilité qui se situe autour de 12 mois. Mais je parle sous la couverture du professeur Barlami qui suit. Il pourra toutefois compléter. Et merci beaucoup.
Thank you so much. So I would like to maybe stop here to allow time for you guys to go to the Metimeter and answer the question. It has been sent to the chat. I don't know if you have issue getting them. So I really want to apologize to, I don't know if there was a question to Laminou and Bibiche. I do believe that the question answer also covers something that is linked to DMPA and UNICEF. I really appreciate understanding. So if you can go to the chat and click on the Metimeter, you have a question there and you can respond directly to the question, and then we'll see the outcome soon. You click on the link. So I hope everyone is there. If you have issue, let us know. We have only 2-3 minutes to do it. And you can also, in the chat, tell us what is your takeaway, your top takeaway from today's session. That will be good. From the chat, you can put it. What is your top takeaway from today's session? This is in addition to what you're putting in the Metimeter, and we really appreciate it. Somebody has the mic on and we are hearing the background. So we have 1 minute to go. Okay, so I think we are ready to go. And what is your takeaway? I don't know if people have been able to respond to that in the chat box. That will also be area of interest. But anytime you can continue to do it. So what I want to say is this session today offers us opportunity to really have a better understanding on how we are moving from design to implementation, and also understanding the regulatory impact or importance in how we can move with self-care tools and technology, understanding that sometimes to move from the design to the implementation, we have a lot of challenges to consider. So I'm happy that we were able to have some field level experience showing us what is happening in the field. And we are seeing a lot of opportunity for integration, a lot of opportunity for involving the customer during the design as well as during the implementation. So I hope everyone enjoy getting something, learning from these experiences, and will continue to explore other avenues, how we can be more efficient in providing self-care to people where they want at the time they need it. I really want to take this opportunity to thank all of you, all the organizers, participants around the world who have been able to spend time and convene for this very important session. So thank you so much. And let's have one closing short film by the team, by the organizers. So thank you so much. Is Kim over to you, or Natalia?